This is the poster. This is a poster, colored poster, that we attached in the operating room and also in intensive care with the preoperative assessment, intraoperative and postoperative safety. So try to summarize everything. So also very practical. So this is the case that we can discuss point by point. You are in the 5 a.m. in the emergency surgical department. And this is the patient arriving. He's a patient of 53 years old, weight 135, is the age 165, so the BMI is around 50, so quite obese patient. This is the real patient. And is admitted for suspected appendicitis with abdominal pain, nausea, and diarrhea. There were no allergies, no smoking, a little bit history of COPD, but without any reported medical treatment. There's some hypertension with a sartanic, treated with a sartanic, and decreased exercise tolerance, and refers to sleep with 4 pillows, so means that there is some difficult from this. This is just to remind you, some scores that I think are very helpful in the organization of obese patients in general. This is the mortality risk score that we recommended to use in our guidelines. Is a relatively very simple, BMI higher than 50, so this is the limit, but I mean, male gender, hypertension, risk of pulmonary embolism, and older than 45. And when the obesity surgery, mortality risk score is a 4 to 5, this is a good indication.
Sleep apnea is not included?
In this score is not included, but in others are. I will show you. So this is, but this is one of the most common. And probably because when you have more than 50, you have also sleep apnea. Yes. And so anyway, when you have a score higher than 4 or 5, this suggests that you have to take care in the postoperative in more environment area. And you see that if you have 4 to 5, the mortality reported is around 3 to 4 or 5%, so quite high. Very high. So these are other recommendations that we published in 2016. These were not included in the guidelines. We were published later. Again, you see body mass more than 50. You see OSA. This is written by me, myself, and colleagues in Brazil. And need for respiratory cardiac monitoring, glycemic control, which is always maybe a problem in these patients, and intersurgical and anesthetic complications. So of course, this is something that we discussed not too much yesterday, but I think one is the possible prediction before and then what happens during surgery. And as we discussed with some of you, we found that 2 complications are very important related to postoperative monitoring. One is some desaturation during surgery, and the second is hemodynamic impairment. If you have this, anyway, even if you have not high risk, you have to be very careful after. So this is the malampati of this patient, you see. Not bad, eh? Not bad. Yes, everything. So all the possible. What do you think, Albert?
Is important.
Now we discuss in malampati. You know that there are some issues, some that shows now. Do you know that malampati might be associated with the Cormac? No, this is the view, as you know. But then I have some, the question is, I don't know if I have the slide, no, probably I have not here. Probably is later when we intubate the patient. But malampati is considered in one of the scores. Now I show, here, you see malampati. Now we discuss that. So the predictors for difficult mask intubation are different. You see different acronyms. One can choose whatever you want, are very different. No? In this they include the malampati, in this there is no malampati, but bordered, edenturus, and these are very similar to this one. So what we use and we suggested in the Italian guidelines is the Engazzuri score, which I think is very good. It's very good because it makes together many things. So the mouth opening, and we have seen the patient was not very good for that. The theromental distance, and you notice that the theromental distance was not very good. The Mallampati and the neck, where is the... where is the, here there is the, here is not the neck, in this there is not the neck circumference, but more than 60 centimeters, I never know the inches, but anyway, 55, 60 centimeters of circumference, they have increased risk. And in obesity, Mallampati and neck circumference are very important to measure. The neck movement, the ability to prognate, body weight, that of course, and the history of difficult intubation. In this, there is not the neck circumference that anyway is considered, I like very much, and higher than 55, together with Mallampati, are very associated with this. Usually, with this score, it's just an idea. I'm not saying that we have to be fixed in everything, but just usually when you have the assessment between 0 to 3, you have not much difficulties. It's not the case of our patient that probably is when this is high, this was very high. The neck movement was half, I remember. The ability to prognate not much. The weight was higher, so it was for sure very high, okay? In this case was 1, then he had here 3, 5, this was 1, I remember 6, 7, 8, 8, 8, 9, okay? So it's around here. So when you have between 4 to 7, is considered the video laryngoscope that now we use also very much in intensive care also. In emergency, we have 1 there. And higher than 8 is suggested awake with fibroscope. Now there is a tendency, at least in our hospital, we were very much used to use the fibroscope more often in the past. Now we have a tendency to look, first look and then to adapt. So less use of fibroscope. But anyway, in this case, we will see what the anesthesiologist did. So this is, again, from our recommendation. This is, you see, just few lines, the preparative evaluation. Standard scoring for difficult areas and preparative evaluation in the presence of metabolic syndrome, neck circumference. You see that we recommend in our guidelines. This was a score just to show you. The aspiration risk for GERD, the waist to hip ratio, BMI higher than 50, and the stop band that now we discussed. And this information must be reported by the anesthesiological team on the medical reports, and the locally started protocol must identify role and responsibility in decision making. That's what we wrote in order to make some organizative point in our unit. For more particular cardiorespiratory evaluation, this is always a question to be discussed. What we say that in respiratory care screen for all surgical patients for central obesity and metabolic syndrome. So the patient should undergo cardiological, including echocardio or pulmonary assessment or both. When there was a stop bang, we were more conservative. You know that it suggested 3. We were more conservative at 5 in order to not to have too much. And especially when we have a metabolic equivalent less than 4, this means that you are not able to do at least 4 steps, step floors. Peripheral saturation, you see less than 94 in supine position ambient, diagnosis of OSA, and inability to use CPAP at home. When you have these, we recommended to have a more deep evaluation in terms of cardiothoracic evaluation.
But most of the Met score will be less than 4 in this age group because of the knee joint pains.
Yes, this is.
So it's not a,
is not, but basically, but this was included in order to, because this was considered as a parameter which might combine the cardiovascular and the pulmonary.
you should do cardiopulmonary testing.
Yes. But then, I mean, no, but what I mean, if you have something like that, in order to, the question that we discussed, then it's open, of course, for discussion, is to avoid too much examinations. Because otherwise you have the obese patient and you start to ask, this is an emergency, this case, but in elective, and then the cardiologist, the pneumologist, the OSA, and it's impossible.
You know, in our hospital,
yes,
we have a BMI of more than 50,
yes,
we go systematically for echo, which is not a bad thing.
No, it's not bad. So no, I mean, if you have you see that if you have a BMI higher than a 50, anyway, a more careful evaluation should be considered. In our case, we preferred to have, when they have a stop bang higher than 5, and especially if they have some of them, we did not say higher than 50, because, I mean, higher than 50 is very likely to have a positive stop bang. So then you can decide if you to discriminate from one side or another. And we included the metabolic equivalent or something similar in order to combine the cardio with the respiratory, which, of course, this is you need a specific test, but you can easily, if the patient has difficulties to stair 10 stairs, of course, this is in this line. This is the stop bang, as you know, remember, and so you have the snoring history, if it's tired, anyone stop breathing during sleep, blood pressure, BMI. This is even more than 35, is included in stop bang. Age is 50, neck circumference, 40, in stop bang usually is more than 50, and gender. Usually, you see, we took a lot of attention of the stop bang, but we have a higher threshold, so higher than equal than 5, so not 3. That you know, answer yes, 3 or more. This is what is in the original, but we avoided this because otherwise you have to follow up to monitor to pre-evaluate almost all patients. That's what we don't want to have, because I can tell you really the complication of these patients now in laparoscopy, that most are very small. As you told you yesterday, in the Probese trial, we had to randomize more than the BMI higher than 40, more than 2,000 patients. Why? Because the study was planned for 1,000. At the interim analysis, we found that the complication was lower than expected, so it was recommended to increase the number. So I think that one message, then we will see the real numbers. But the complication, yeah?
Take all these patients, the bariatric surgery, we do it in anti-transverse position, which may explain why you have less complication.
Exactly. Reverse transverse, yes. With the head up. Yes. In fact, what I mean is that sometimes there is too much. So what we try to discuss, but is open for discussion, is that in our guidelines we try to limit the overwhelm of examination, and to limit examination to those patients that are likely to have more risk. That was the philosophy that can be debatable, but it's what we did. I tell you our experience, because the complication that we have is relatively very much low. So it's lower than expected for this reason. Laparoscopy, position, type of intervention. Of course, then it depends. So this is something. This is what we do. You see it also from recommendation. So you have known also, for example, prolonged stay in the PACU for 3 hours. You have the known of also even in the PACU. You have one of these events, so recurrent PACU respiratory event. You can imagine the patient is discharged. I should put the slide afterwards of the case, but just to remind. If happens the desaturation or bradypnea, this is rare, or some apnea or some pain sedation, one of these events or history of severe OSA, of course, or non-compliant to the positive pressure therapy. If the patient has none of these, so in the PACU was good, and there's no postoperative need of major opioids or no OSA, the patients can follow in the ward and then discharged in a few days. In two days, usually our patient maximum 3 days are discharged. If yes, so if there are no events in the PACU, but we have a story of OSA, or you needed some more opioids for pain, in this case, the patient is sent to the ward with more or less the normal condition.
Okay, you did mention the type of surgery also here.
Yes, the type of surgery, of course. If it is this, I'm talking about the bariatric surgery. Yes, of course. If you are talking about more surgery, obviously, yes. If you have an occurrence of one of these in the PACU, then we prefer to move the patient in a more in a sort of intermediate care. So we check for at least 2-3 hours. We have a sort of we have not a PACU, we have a large room just after the operation room where we have all patients there and they are monitoring. If the patient has a suspected OSA or high-risk patients and recurrent PACU event, of course, is also have this kind of therapy. If the patient have no recurrent edema events, even with some suspected OSA, the patient, if it's minor surgery, stay 1 day, of course, in the hospital, then is discharged, or is going to the postoperative ward. So at the end, you combine the presence or not of OSA and what is happening in the post-op. So because this is a one message, then we can agree or not. You can have whatever condition before, but if you are not developing something worse in the early phase after surgery, at extubation, it's very unlikely that the patient will develop further complication, unless surgical, of course. So the PACU is very important on how to determine what's going after. That's why we take a lot of care of these 3, 4, 5 hours in the PACU, in the postoperative area, before to decide going to the ward, going to the intermediate, going to intensive care.
Extended recovery.
Extended recovery. Not 20, some people at 12 or 12, not so much, we cannot organize that. But we have a possibility up to 4 hours. Yes, this is the message, then we can agree or not, this is what we do. So the patient now is at 7 emergency surgical department, and he has some supraventricular tachycardia. Temperature is not high, laboratory analysis is normal except glycemia. These patients always stay here. Of course, if you have major problems in glycemia, they have to go to intermediate for control. Some of us agree, others with the other drugs. Alberto, what you do in your practice?
Same school.
You are?
I call a Korean and say, do the patient. I'm the boss.
So, this is just to remind you that the opioids, and then we will discuss a little bit later, they can now promote further OSA obstruction, You see here during the administration, the nasal signal here, and also activities in the clavicular, so you have more difficult to breathe in this time. Then you have the relaxation of the muscles here. So the patient is transferred to the operating room at this point. And now we have to have different things to discuss. So positioning of the patients, I think we agree, no?
Yes.
For head up, no? For, as we discussed today. This, I think, yes. So now we type of intubation, then we discuss the type, but you prefer to, do you use some non-invasive before or not? Just intubation? No.
Bariatric, how to
In bariatric. No emergency. I mean, we are emergency, but not super emergency. Okay. Can be also full stomach, so I would be very careful. Yes, I agree. Then we discuss the ventricle, and then we discuss the anesthesia. Now, point by point. So supinal head up. All of you, we agree, chooses to use head up. Okay, we agree on that, no? Always in obese subject, we discussed that, the RAM position. And is superior to standard knee position for direct angle sway, at least in morbidly obese patients.
This is not enough.
This is not, I absolutely agree. You like that. You see? I wanted to have a joke. This is the,
For a surgeon.
yeah, this is from the studies, and this is what, this is the reality, you see. So I anticipated you. And so reverse Trendelenburg plus, and then you, okay. What about the difficult intubation? Now we discussed before. Really, the difficult intubation is reported in 10% of obese patients. So,
I'm going to tell you, we've been doing that for 4 years now, regularly, and we have high BMI. Personally, I've never had any difficulty.
Exactly. So that's the point, that there is always this thing that BMI and difficult intubation is contradictory, you see, and most experts believe that it does represent a greater potential than the average patient. So it's supposed to be more difficult than it is really. So it's important to facilitate intubation to increase the duration of the apnea duration, to increase the apnea duration. We don't discuss this. We have just seen, not in this case, which is emergency, but can be now. In most of cases, we use, however, positive pressure before intubation.
For how long is a positive pressure can be applied? Even 5 minutes, right?
No, we start 3 minutes, 4 minutes with positive pressure or CPAP.
So what is the problem to put it in this patient?
No, even you can do also in this patient. I mean,
if we take 3 minutes,
you can also, but if the patient has a full stomach,
And also you inflate the stomach.
you can have a risk of infection because you have not.
we
But
can use only CPAP in this.
we can use also CPAP, 5. I agree, without pressure support. This is another possibility. Yes.
But I think this kind of problems, it's better to give a large dose of procuronium, 1 minute, you intubate them rapidly rather than do that.
This is open for, is the role of non-invasive. One can choose to use or not. In some, now we can say that now we have another option, that is to use the high flow, which I think is a very good one, because if you use high flow here, you don't have the problem that you report. You have a very good oxygenation, you have a very good washout of the dead space, and you prepare an optimal intubation.
But why take time to intubate them if we can intubate rapidly? Is rocuronium now?
No, the question is, again, you have to balance the risk of difficult, but there's also the problem of ventilation or not. I mean, if you don't have any problem, of course you have no problem. I mean, yes.
Scoline.
So,
Scoline, what about?
What?
Rapid, Scoline, for rapid intubation.
For succinylcholine, we have not anymore, so we have only rocuronium now.
No, 1 to 2 milligrams is enough for rapid intubation.
we can do also rapid. No, I mean, the question is not the rapid. The question is that if you are then able to intubate.
Back mask. If you can back
And you get back mask, you can absolutely. Yeah, I agree. The question is that the idea to have this is that you are prepared for a longer safety for intubation. So these are different options. Then you can choose, but just to show that you have different options. I'm not saying that one. Of course, we have to be ready for everything, and now we have to decide the type of intubation. What you would do? You would do conventionally. Video, or video or fibroscope? Video.
You know, CMAC is, I think that CMAC is solved.
It's good. Exactly.
I don't use it because
At this time, I agree with you. At this time, it was used the fibroscope because we were but the anesthetist decided for a fibroscope and calls for an help, of course. This is always important in any case.
other colleague. To put in trouble other colleagues.
To the other colleague. Better, however, two than one, but I agree that I would use the video laryngoscope. I mean, you know that, no? So there is no question that usually we get a good mark. And this was what I was telling you before. The C-track is very good also for this, but we have, you have this, you have that. The C-track is very good, and these are the different. This is the entry as we discussed before. Is another possibility. You can use this as an example with the laryngeal. You can use with that. If you have difficulty, you put the fibroscope, then the entry, and then you do like this. Okay. So then we have to decide the type of anesthesia. Usually we use sevoflurane or desflurane. Desflurane you have.
We're using dexmedetomidine.
Exactly. Then you have dexmedetomidine, but we cannot use in anesthesia in Italy. No, because it's only for is not licensed for that. But I agree. Then we discuss this. I like very much dexmedetomidine. Then we use the remifentanil if you decide to do the opioid. Then we discuss a bit the non-opioid. But we are in my hospital, the non-opioid I try to introduce. I'm not in anesthesia now. I'm an anesthetist, but so I'm in intensive care, so I have to be very polite because
the use of dexmedetomidine, xylocaine, we use a very low.
Very low, but there is no license, so.
Even in the pamphlet, now.
Yes, there is exactly. It's a great pity. And then in this case was suggested the cisatracurium. Now we use a lot rocuronium. So it's the only one that we have. And Sugamadex, yes. In these patients, rocuronium is Sugamadex. So this, I think we agree on this. This is why avoiding the opioids, no? This is another choice, to do the non-opioid. Do you do some non-opioid anesthesia? So these are all possible advantages of not using opioids. No side effects. Sometimes they do not treat all pain problems. They may induce immunosuppression. They may induce some neurotoxicity. They have acute tolerance and addiction. This is a problem coming out. Hyperalgesia, this is very important, and some chronic post-surgical pain. So this is the long list. I agree, Alberto. This was given to me by Moulier. He's a fan of this. I was in Bruges. We were there, no? And so it's just to show. And this is the protocol in Brugge that they do. So it's a very complex protocol, to me too much complex. They use dexamethasone before induction, that even is a good choice for that, and droperidol, that I would be very good. It's a cocktail. Then you see, as our colleague said, the dexmedetomidine. They use a bolus because this is, as I told you, Alberto, in intensive care we never use a bolus because this may produce
Actually, it's not a bolus, it's a loading dose.
a loading dose in 10 minutes. It's not boluses, yes. Then they start with propofol, followed by inhalation, and bis, okay, around 40, which then they give magnet sulfate, rocuronium, okay, this is maybe on ideal body weight. This is hypertension, and they add some ketamine before at the end to cover for the pain. You are doing that. And then they do the wound infiltration systematically.
At the final, you don't know in which way you kill the patient.
At the end, yes. So this is what they do in my hospital. Was impossible to discuss something like that. To me, it's too much complicated. But if we simplify, I think that there is something not bad.
We are doing 5 or 6
Of this. Yes, exactly. I agree. So if you choose 4 or 5 of that, the most important is reasonable. Of course, we cannot do that with DEX, and so this is a major issue because if you don't use DEX, of course, it's important. Okay, now we have to discuss ventilation. Now, this is we intubated, so tidal volume. How many of you actually? I'm not saying this is correct or not. We have no clear evidence on that. But how much tidal volume do you use? Do you use more protective or you continue more protective, even in obesity?
body weight,
Yeah?
6 to 8.
6 to 8. And respiratory rate according to
the ATC.
the ATC2. PEEP, which is the PEEP that you use on average?
6 to 8.
6 to 8. 6 to 8. Okay, so...
The problem with this patient, they're usually young. They don't have difficult lungs.
Yes, usually they have not much problems, yes, during surgery. Okay, so this is the setting of the ventilator at that time. They use very high tidal volume, you see, in that case. They use low respiratory rate. This is the reality, It was some years ago, this, But just to make...
Why did it show me that?
they use PEEP5. Peak airway pressure was very high because this was in volume control. So we have to remember pressure regulated. I like very much pressure regulated volume control in this case, yes.
Volume control autoflow is volume control is autoflow is very
Or autoflow, yes, with decelerating flow, yes. Is the same thing with decelerating, absolutely. So this is just fun, don't record. But when I presented the case, our protocol, the first the probase trial, in our unit, in our hospital. Of course, I'm not the director of our anesthesia, because I'm the director of intensive care, but I presented the protocol because then I went to the ICU, to the operating room at the beginning, because all the anesthetists were worried. First, the tidal volume was first a big step, and the second, the PEEP. It was low PEEP, high PEEP, how to do recruitment. And the question was, okay, I say we have to ventilate in volume control because for the protocol, I like more pressure, but for the simplicity of the protocol and the majority, blah, blah, it was the selected. Okay, I went there, I said, okay, we have to set the tidal volume between 6 to 8 according to the protocol, and say, you cannot do that because the ventilator does not work. I say, come on, the ventilator does not work. Yes, because when we put in volume controlled, the ventilator is cycling, while in pressure control it is not cycling. I say, what is that? And then I understood, because in pressure in volume the peak is higher. They were used to put the alarm at 25 in pressure, so it was cycling. I said, very simple. You increase the alarm of the ventilator, the problem is solved. So And I remind you the importance of auto-PEEP. The auto-PEEP in these patients, I don't know if I have some slides, but it can be up to 12, 15 centimeters of water. This is the main cause of hemodynamic impairment in obese patients. And you notice the ventilator here that we had. It was not possible with this one to do any expiratory pause. You can do with the new one, what is I always confound the Zeus and the other. They are the big, the largest, the newest one. They can end respiratory. The Zeus, no, is the, and while this was the Primus. The Primus does not allow to do this, while the Zeus, which is topper, is able to do that. The other point is end tidal and peripheral CO2. We measured even during probese. One of the alarm in the probese was that we ventilate with low tidal volume, all patients. So some patients have higher end tidal CO2. So we started to measure for safety the peripheral CO2, but we found that in obese patients was not very much correlated with arterial. So I don't think is a very good monitoring.
Sorry, boss. How can I was talking with
Yes.
How can I don't understand. How can you set? How can consider better PEEP intrinsic when you put the PEEP?
By expiratory occlusion.
Yeah. How you consider if you find 12?
If you have 12,
In this way,
means
type of patient.
This type of patient usually. So if you have in these patients, you have to look at the curve as we looked at yesterday. If there is most of the cases in these patients, they can have or asthmatic attack or so narrowing, or to have a collapse, mainly when they are in supine. But if they are in reverse, it's less. If you have the collapse, usually when we apply 6 to 8, this should be avoided. But if you have auto-PEEP in presence of 6, this is likely to have. You can have a look at the resistance, or most of the cases we discussed that in this case.
Also, you show the picture about the patient sitting or step.
Yes. It's a big difference.
The big difference about auto-PEEP.
Absolutely.
Also the compliance
It's different. Yes, can change. So one can suspect. We discussed because it's later. It happens.
Sorry.
It happens later. So the recruitment we discussed. We have to remember that the entitled when we have this curve. No, this cannot be. So it takes more time before you have entitled below the real value in some patients. So we have to be careful of the monitoring of entitled CO2. So now we have a sudden increase in the peak pressure because this was in volume controlled. If you are in pressure control, we have a reduction in the lung volume. So, and heart rate is 100, systolic is 100, 115, saturation is lower, because you have FL2 is high, saturation is low, and tidal in 49. So the anesthetist auscultate the lung, and there is no sounds, and it's likely to have perhaps bronchospasm. We don't know. And you have to remember the accidental movement of the tube is more frequent in obese patients than in normal subjects, which can make some difference. So in the differential diagnosis, first to check the tube. The tube is very important. Causes of wheezing, not due to bronchospasm. One is bronchospasm, as we say. But other are mechanical obstruction to the tube or kinking, endobronchial intubation, probably possible development of edema. Others are less frequent here. And we can have a look, if you are in volume control, we can have an inspiratory pause, if the plateau pressure increased, is more likely to be the lung, so non-obstruction. If it is the airway resistance, you have an increasing difference between peak and plateau. This can be one, but you need the occlusion that you have on Zeus and you have not in other ventilator. This is just to remind here that you see some patients, this is non-flow limited or flow limited. You see that in supine, many patients came from non-flow limited to flow limited, as we said. So, but now with the reverse, you have less. But if you are in supine, is one of the main cases and autopip is around 6 up to 12. So autopip is something that is not considered in anesthesia. Perhaps in COPD, but not in obese, while in obese is relevant. And this is now you know how to measure, so with the expiratory occlusion, no? You see here, and I think this is very important. You have this, so the flow is not going to zero, and you remember yesterday the flow volume curve. If you have airway obstruction, we have like this, otherwise you have more linear with autopip. So, in case of bronchoinea, what's your choice for treatment?
Bronchospasm.
Bronchospasm? Broncho?
Ketamine.
Get some inhalation.
Inhalation, sure, okay. But this is you have, and then you add some beta 2. You give intravenous or inhalation in puffs. And corticosteroids, do you use?
Yes, hydrocortisone in some cases.
In some cases. Which type?
We're giving Dexa before.
Hydrocortisone.
You give, if you did dexamethasone before,
No point giving that.
it's possible that you reduce that risk. This is true.
Some magnesium sulfate also become bronchodilation.
All right, now this, the cause of the bronchospasm, maybe light anesthesia, maybe yes. This will happen in reality, so. In this case, this is a typical from Italy. They use salbutamol intravenously, which is perhaps too much. I think I would use the puff, but this is
from the start.
and hydrocortisone. But I also would use puff at the beginning. Now I don't know if you have here, but we have a very good experience with the new mesh nebulizer that you can put. This is more in the anesthesia is less. Yes. Anyway. The patient's the pressure drops a little bit again. The anesthetist starts to give fluids. At the time there was no PPV, some fluids. They started dopamine. I would never started dopamine, but they started dopamine with fluids. Okay.
Why are you laughing?
And
Why are you laughing?
and just to remind that the role of autopip, in the hemodynamic issues, So not to be too stressed. I mean, you have to solve the autopip.
Do you think we should put invasive monitoring? I mean, arterial for this?
This is a good question. Actually, we don't do that routinely, but I think it's a good choice to do the one for. Because here, for example, is when you increase the pressure in the abdomen. For example, we discussed the PPV or stroke volume with VGLEO, so non-calibrated, might be useful. But when you have an increase in intra-abdominal pressure, you have to remember to increase the threshold. So if it is 13, we have seen, when you have increased intra-abdominal pressure, you have to go around 17. So the threshold for PPV or SVV, when you increase the pressure, like laparoscopy, you have to add 5-6%. Is another case where you are at the limit of the use. But in the polyclinical, we were used to cannulate the artery and then to remove.
BMI more than 50?
More than 50, I think, is worthwhile. Absolutely, yes. So the patient in operating room, procedures ends, and these are the parameters. Now they even remove the PEEP. that I don't understand. Respirate rate low, high tidal volume, peak is always high, pressure now is back with some dopamine, saturation 100%, in tidal is okay, hemogas analysis is so and so, but reasonable.
250.
Yeah, it's at 250, exactly. Now no evidence of bronchospasm. Ecco, in a patient like this, no, more or less, with this parameter, what do? You decide to extubate in the operating room, or you prefer to wait for
It
extubation?
depends on the cause of the
It depends on the situation.
If it was like anesthesia, we solve it.
It was solved, at the end it was solved. So the bronchospasm was solved.
Backup ICU shift or no? What can
In this patient, you did not, because the patient arrived there, so you have not booked an ICU. So now you have to decide if extubate and go to the
High dependency.
ward. High dependency. If available. You are not agree? Peters, you extubate.
And hypovolemic and inotropes.
Eh?
It's still an ICU.
Yes, then Mike's.
You would go to monitoring.
Yeah.
Yes,
but
yes.
Not high dip.
Not high dip.
Take even the risk of this, Better to stabilize the patient more.
More, okay, in the PACU.
And the PACO, which is, because there's much difference between our PACO and your
I mean,
in your PACO, it's maybe up to 48 hours you can keep it.
no. Our PACU,
But in
no.
our PACO, it's maximum 2-3 hours.
Yes, like our, yeah.
Immediately.
Then we have to decide what to do.
Yeah, I would arrange with, the
But my question is that now the patient, we are in the operating room, okay, with this condition and with this story, okay? Now the patient, what we do, intubated in the area just outside, and we wait and we see. We extubate and we go there. We extubate and we go to the ward. We call the intermediate. What we do?
I think we can try extubation, keep observation, and then
What
decide.
high stabilize keep intubated?
So here we have two parties, the extubation and we waited, the patient await extubation. What?
How long was the operation?
The operation was 2 hours.
May extubate the patient in recovery.
Yeah, and observe, and eventually decide. Even 4 hours.
Okay, so, yes.
I mean, after the surgery and after all this,
Yes.
got here, can we get also, what is the results before we decide, extubation or?
Extubate the patient. Extubate the patient.
ABG, I don't like ABG. I don't like it.
The ABG, since Alberto liked the ABG, you see, here it was done, the ABG. No, yeah. And now we have this ABG. This is not, look at this,
Suppose,
these small numbers here.
suppose that they have hemoglobin 10.
Now,
Suppose the VO2 is 0.5.
yes.
But why keep
Hemoglobin
imaging?
calculate means you have a sharp.
Why? Yes. No, but in fact the question is that because this is the usual question. So if you when we receive the patient in ICU, if the patient is intubated, okay. But when the patient is not intubated, we complain as intensely. Why? With the anesthesia is coming. Oh, why it is not intubated? He could go. So
It's the opposite, huh?
it's the opposite. It's the opposite.
If you extubate, they're very happy.
So, I see that there is no agreement. As usual. So I see, we go on, we see what happens, I don't remember. So if you are not sure that we'll be able to breathe, okay, this is a general rules. We have to remember that desaturation was something that to take, you remember, desaturation was one of the parameters, blah, blah. At 3 p.m., the patient is transferred to the ICU, intubated. But now we see what happens, because you don't know what happens. So now the patient is just decided like you. I'm not saying that one is right or not. Now we follow his...
And also question is the safe hands.
He's safe hands now, you are safe. So the anesthetist now, anyways, now is going to in intensive care, okay? So the patient, with now rocuronium, whatever you want. So pressure now with some dopamine, glycemia 360, Again, mechanical ventilated like this. So is a patient with some not solved the problems. Sedation is progressively reduced. Analgesia, in this case, morphine, we can, this was whatever they do, it was done. Amicus symmetry, we can discuss why amicus, but for me, this is piperacillin. I would use piperacillin tazobactam and or PP is increased because now we are in intensive care. At that time, anesthesiologists were not. Without previous recruitment, SIMV3 breath, okay. Sometimes we have some pressure support. Gas analysis at 0.4, 81. We have always some this base excess that is not, and hypoxemic patient. So, this is the post-operative analgesia from Brugge. Paracetamol, diclofenac, a lot of things like this. Okay, more or less we do similarly also in our patients. We don't use too much others. Yes. This is the complex, very complex. They like the magnesium that they like.
They like to show that they are able to think.
Yes. But I just show magnesium.
In itself, it can cause muscle weakness.
Exactly. In fact, I think it's too much complex. I just show because Jan told me. Exactly. No, but this is not what we did. It was done. This is the recommendation from Moulier about the post-operative.
Exactly.
So 7:30 p.m. now, we are p.m. Is intensive care. This is what is written in the clinical chart. So patient is contactable, but persisting light curarization is intolerant to the tube and agitated. Tidal volume are good, pressure support. Now, it is impossible to obtain vital capacity. These are the in sequence. No temperature, pressure is good. No more vasoactive drugs, urine is okay, but no one is looking for spontaneous cough or ability. That I think is very important. No, that sometimes we forget. No, even in intensive care, how much is the ability?
Prefer to extubate the patient.
Then one can have a look.
Because they don't know how to do it.
However, now, with this, the patient is like this now, no dopamine, what we do? We extubate now. You repeat an EBG that is not repeated, as you can see here, is not repeated.
Because the young people, the lazy boy.
This is not repeated. This is, I cannot anticipate what happens. It's a real story, It's a real story. At 8:30, this is very important, 8:30 p.m., that's I wrote the hours. That's the point. Now we are at 8:30 before the night. The obese patient, not good.
Morning better.
Decide to extubate.
He's stuck.
Look at that. Moderate the bronchospasm, come again. It's a true story, After extubation, and they give some hydrocortisone. At 9, progressive deterioration of consciousness, dyspnea, marked desaturation. Pressure is okay, heart rate is higher because you are stressed now. You and the patient.
The reverse muscle relaxant in ICU.
They gave some prostacyclin. Yes. And they need to reintubate. They need to reintubate because the patient deteriorated. So we don't know if you had extubated early, what's happening, of course, but it was followed in ICU. It was not performed, two things. First, no one performed the chest X-ray, echo or whatever. Echo is difficult in this patient, at least a chest X-ray. And no one performed a gas analysis.
An ultrasound.
Ultrasound, is far. Ultrasound or chest X-ray or gas analysis. There are not. The criteria was that the patient has a 40%, nothing like this. It's a patient after surgery, no major problems. Now you are too much confident and you extubate. So they reintubate the patient with a difficult intubation, because this was a difficult patient after, so with 5 attempts, with them, difficult. No, this is intubation. And they perform a chest X-ray. This is the chest X-ray.
Finally.
Look at that. They position a CVC that was not positioned before. They do a chest is 18 millimeter of mercury, so the patient is even well filled. And this is the chest X-ray. You see here, there is some atelectasis on the left lobe. If you were done a chest X-ray, or more carefully a saturation in air, probably it was 85, 87, just oxygen there, and you masked the possible problems and whatever. Anyway, this is just to say that was...
And now we have a central line.
And now we have a central line.
We can be more accurate with the CV.
With everything, yes. With everything, yes. So, one question now is probably to perform eventually a fibroscopy to clean the atelectasis. And at 10:30 a.m., so the day after, there is a progressive reduction in sedation. You see the chest X-ray much better. The patient is going well now. Everything is fine, no bronchospasm, cough present, secretions. The bronchoscopy, yes.
But they increase dopamine again during...
I don't know, they did some dopamine, there was some, and the terminized nothing. So at this point, they attempt the next extubation, no, because now everything is in.
Consultant available.
Yeah.
Morning time, huh?
But the patient is extubated, uses a Cook area exchanger catheter with some safety to protect the airways, and 1 hour after extubation, everything is going well. No oxygen, and no oxygen we have 93, so probably there is again something, but it's
Finish the dopamine.
Yes, dopamine they was contained something. Yes, suspended. And this is what we discussed today. Okay. Personally, in these patients after extubation, I would use some high flow or some CPAP, as we discussed. High flow now is
in the
good.
end, what was the diagnosis? Why the complication happened?
No, it was never, as far as I remember, was never.
I think because they didn't
But probably,
extubate the patient.
what is it? It's possible that it was maintained.
The true means keeping sedation.
They maintained and promoted the atelectasis. It's possible, absolutely. I think 2 factors, that they use very low PEEP, perhaps, no? Even I think, you remember, 0, and second, they did not do recruitment. You remember, it was written no recruitment. So, it's possible that there was this, from this point of view, not particular attention to the management. Absolutely. I agree with you. Then this is the physiotherapy, this is what we discussed today. This is our recommendation in the peripheral ventilation that should be done to prevent postoperative, and CPAP on MPPV can be considered in selected patients. Obese patients with some, not all obese, but in obese, some, and there is no evidence to interfere. This was a question that we had. No, there is no evidence that this procedure may interfere with surgical anastomosis if you don't exceed 20-22 centimeters of water of pressure. So 10:30, the pressure reduction, everything is fine now. No, this is probably okay. The patient then is discharged, is okay. So this, I think, stimulated discussion.
I think that this patient picture